Hello everyone, happy Bonal to everyone who's celebrating today. And today I'm going to go ahead with my next session, which is going to be in continuation with the topics which we're doing of GIT. And today I'll be talking about persistent diarrhea. Okay, so today's topic is persistent diarrhea. It's not going to be so long, but we need to understand the basics of this so that we can understand what is chronic diarrhea and what is persistent diarrhea and the management of both separately. All right. So now, starting with it. So first we will know what's the definition. Okay. What is the definition of persistent diarrhea? So persistent diarrhea is a diarrheal illness. Okay. This is persistent diarrhea is a diarrheal illness with passage of more than equal to 3 loose stools per day of presumed infectious etiology. Okay, that is the main thing, infectious etiology, and it starts acutely. This has started as an acute diarrhea, started acutely, okay, and has lasted for more than or equal to 14 days, because that's the cutoff for acute diarrhea. All right. So what you need to know is this definition means the main thing is 3 loose stools per day and the infectious etiology. That is more important thing. Going ahead, after knowing the definition, we need to know what is the pathology, what is happening here, why the diarrhea has gone beyond 14 days and why it has not responded to our normal therapy. Okay, so there's something else which is going on in the body, some pathophysiology. All right. So okay, very sorry. Yeah, so we need to know what is happening right here. Okay, so what is happening is the basic defect. I'll tell first. Basic defect. The basic defect is the small intestinal mucosal damage. All right, and this includes SIBO. What is SIBO? SIBO is small intestinal bacterial overgrowth. Associated with this may be malnutrition, okay, malnutrition, growth failure, with, and this has significant morbidity and mortality. All right. So this was little about the basic defect. Now what else is happening in pathogenesis? What else? So there is a prolonged theories which are there. First one is I'm going to tell you about is prolonged cell mediated immune damage, okay, to small intestinal mucosa of small intestine. Okay, this is the final common pathway. All right, the impairment is considerable and causes delay in repair of the damaged epithelium of the gut. Along with this, because this is happening, what will happen? Carbohydrates, fats, proteins, malabsorption ensues. All right, and due to loss of brush border enzymes, and direct absorption of macromolecular foreign proteins can result in allergy. So this is cow milk protein allergy, or wheat protein, for example. Okay, so these are the this is the final common pathway, that is prolonged cell mediated immune damage of the mucosa of the small intestine, and there is impairment and considerable delay in repair of the damaged epithelium of the gut. Carbohydrate, fat and protein malabsorption will ensue, and the loss of brush border enzymes may sometimes cause allergy to macromolecular foreign particles because of their direct absorption. Okay, and then this is the problem with cow milk protein allergy and wheat protein allergy, that is causing a persistent diarrhea. Okay, so this is a little bit about the pathology and the definition. Okay, what we need to know next is the clinical forms. Clinical forms of persistent diarrhea. Okay, in clinical forms of persistent diarrhea, the first thing which we will discuss is mild. Okay, now in mild, what happens? There are severe loose motions. There are severe loose motions per day. It is without significant weight loss. I'm so sorry. It is without significant weight loss. Okay, without significant weight loss and without any significant dehydration also, in a mild form. And this can be managed as OP basis treatment, that is domiciliary treatment we can give. Now coming next, second one, which is moderate form. In moderate form, you will be having several motions per day. Several motions per day are there, same like the mild form, but in this there will be marginal weight loss. Marginal weight loss, but without dehydration. Okay, without dehydration. Okay, and these need frequent admissions. This leads to frequent admissions. Okay, sometimes in the history you can find out that there is non-tolerance to milk products. This history may be present. Okay, so that was about the moderate form of diarrhea. Now coming next to severe. Severe form of persistent diarrhea. Severe persistent diarrhea. In this severe, the code words, the key words will be life threatening. Life threatening it is. There will be dehydration. The child will be dehydrated. Okay. There will be weight loss. Significant weight loss may be there. Okay. And there may be history of non-tolerance to milk or some cereals. Okay, milk and cereals, non-tolerance. So most likely there will be a secondary infection which coexists with this. Coexists most of the times. Okay, and there is a need to stay in a tertiary care center. In a tertiary care center for indefinite period. How much time? Indefinite period, till they recover. Till they recover. Okay, sometimes they may even require investigations like intestinal biopsy, and they may need interventions like total parenteral nutrition to be given. Okay, you need to remember this. Next thing which I will talk a little bit about is like what can I say, diagnosis. Emergency risk factors. When the patient presents to you, the emergency risk factors must be assessed. Okay, what are the emergency risk factors which you will assess if a case approaches to you with a history of more than 14 days of diarrhea? Okay, you will see whether there is dehydration. You will see whether the patient is malnourished. You will see whether the child is having other infections, and yeah, so these are the emergency risk factors, and you will be sending stool for culture. You may send stool for reducing substances and stool pH also. Okay, so this all should be sent in diagnosis. Now this is basically overall a simpler topic. So for now we have discussed about the definition of persistent diarrhea, basic defect, which is the final common pathway. Okay, and then we have discussed a little bit about what are the multifactors which can lead, and then clinical forms which are mild, moderate and severe. Okay, and then diagnosis. In diagnosis we'll look for these risk factors which are high risk factors. Dehydration is present in the child, malnutrition is present, and infections. And what you will send, very important investigation, is stool, which you will send for culture, reducing substances, pH and etc. Okay, so yeah, so that was about the diagnosis which we will be concerned with. And now now we'll be talking about the management guidelines. Management guidelines of persistent diarrhea. What are the management guidelines? Now according to the clinical presentation we will do the management. So there will be a management of mild persistent diarrhea, moderate persistent diarrhea and severe persistent diarrhea separately. Okay, now mild persistent diarrhea. Okay, for mild persistent diarrhea we will try low milk formula feeds. Low milk formula feeds which can have rice, milk, sugar and oil. This diet is called as plan A diet. Okay, this is called plan A diet. Okay, low milk formula feeds. Coming to moderate persistent diarrhea, you will be going ahead with not trying milk. So do not try milk in these patients. Okay, do not try milk in these patients. Permit cereal based feeds. Cereal based feeds can be permitted. Okay, cereal based feeds can be permitted, like rice, okay, and then wheat, okay, and then we have like Bengal gram you can give. Okay, that's not a cereal, pulses, but Bengal gram, ragi, okay, mixed with sugar, oil. Now this is called as diet plan B. Plan B diet. Okay, this is for moderate. Coming to the severe persistent diarrhea. Severe persistent diarrhea, this is done in phases. Okay, severe persistent, I have told you, right, life threatening with dehydration and weight loss. Second, infections is present and they need a lot of investigations like biopsy and indefinite period stay until they recover. So what are we going to do is we are going to talk about it in phases. So in phase 1 of management, you are going to resuscitate. You are going to resuscitate the child. Resuscitate. Okay, this is going to last for less than 24 hours. So you need to correct the dehydration, the dyselectrolytemia and all that stuff. Okay, if the patient is presenting in shock, you need to correct the shock. Okay, now coming next to phase 2. Coming next to phase 2, in phase 2 you will have partial control of diarrhea. Partial control of diarrhea, and you have to sustain the maintenance of the vital signs. Sustain the maintenance of vital signs, because you have corrected the vital signs in the phase 1, so you have to sustain that. All right. Next, you should look for that electrolyte, metabolic and hemodynamic balance is there, and you may, for that purpose, you may even give PPN, that is partial parenteral nutrition. Okay, so electrolyte, metabolic and hemodynamic balance should be maintained in this. You can give IV fluids. Okay, sometimes colloids are also required in these cases in the phase 2. Okay, and parenteral antibiotics should also be started. Parenteral antibiotics, not oral. Okay, parenteral antibiotics which can be given between 1 to 4 days. This is about the phase 2. The phase 3 is gonna start 5 days onwards. From 5 days onwards, you will start the phase 3. 5 days onwards. So this is nothing but something which is called as nutritional rehabilitation. Rehabilitation. Okay, you're going to do nutritional rehabilitation in this. So what are we going to do? We are going to monitor weight. We are going to monitor weight. Okay, you are going to give hypoosmolar. You don't want diarrhea to happen. Hypoosmolar, hypoallergenic, and home available, because it's going to be like a very long period of phase 3 management, right? Homely available, calorie dense, because weight loss has happened, right? Calorie dense. Okay, non offending to the gut. It should not be offending to the gut. Non offending, lactose free diet. Okay, lactose free diet. Now this is as same as the plan B diet. Plan B, which I mentioned up. Okay, those things you can use, and this plan B diet I told you, right? So that you can use, but what happens is you have to do gradual increments of this. You cannot directly just push this plan B diet on them. So there should be a gradual increase in intake, gradual increase depending upon the tolerance. You should look for the tolerance to it. Okay, now sometimes what happens is tolerance fails, or sometimes what happens, with this plan B diet nothing works. So that time you will go with plan C diet. So you will go with plan C diet, and plan C diet is made of chicken, egg white, glucose, and oil, that is sugar and oil. All right, and along with this you may have to give ppn. Okay, that is partial parenteral non. Now suppose to this also response is not there, no response, what will you do? You will go for TPN, total parenteral malnutrition, total parenteral nutrition. Okay, so what we have understood is in mild we can just give low milk formula feeds in which there is rice, milk, sugar, oil, and this is called plan A diet. In moderate we do not try milk, we don't want to offend anything. Cereal based diets we can give rice, wheat, bengal gram, ragi, sugar and oil. Okay, we give it. This is called plan B diet. And in severe in phases, first we need to correct the shock and vitals and everything, maintain them with IV fluids, colloids. Okay, and side by side you can start partial parenteral nutrition. Okay, and start a parenteral antibiotics for 1 to 4 days, and then from 5th day onwards you can start the nutritional rehabilitation of the child. That is, you have to monitor the weight. Okay, and the hypoosmolar, hypoallergenic, okay, diet you should give, which is homely available, calorie dense, okay, lactose free. So with this you can start with plan B and increase gradually, slowly you should give. Okay, and if that fails you can go for plan C diet, which is chicken and egg white based with sugar and oil, and along with this we should be giving a ppn. But suppose this plan C diet with ppn is also not working, then we go for the last one, that is TPN. All right, now a little mention about there are 3 things which you need to know now. The criteria to change over from diet plan from A to B to C. Criteria to change diet plan from A to B to C. Like, how do you know that that diet plan is not working for this child? So there should be some criteria, right? So if A is not working, we'll go with B. If B is not working, we'll go for C, like that. So if we have started and these all are happening, like for example, when I tell you the criteria, you'll understand. Purge volume and rate is more than 7 stools per day at the end of 7 days of the diet plan. At the end of 7 days also, after giving the diet, still the purge volume and rate is more than 7 stools per day, means you have to shift to the higher level. So if you are doing plan A for 7 days you have given and the purge volume is still more than 7 stools per day, you have to go ahead and make it plan B diet. If the same thing is happening with plan B and your 7 days you are not working, then you go to plan C. Okay, and then being on that diet, there's a tendency for the patient to go on the dehydration, tendency to dehydrate. Okay, tendency to dehydrate while being on the diet. Okay, and the third criteria says no weight gain, no weight gain, or there is weight loss despite oral intake of more than 100 kilocalorie per kg per day for how many days? 3 days. So for 3 days, if you are giving this much calorie dense food and still there is no weight gain or weight loss is continuing to happen, you have to upgrade the diet plan from A to B to C. Now till now you must have understood what is A, what is B and what is C. A is a milk rice diet. We have discussed, right? Milk rice diet is A. Plan B is an egg based milk free diet. Egg based milk free diet. Okay, cereal based, okay, with ragi sugar you can give. And then plan C is a chicken based diet. Chicken based diet. Okay, so this is about the overall management of the basics of the management of persistent diarrhea in its clinical forms, that is mild, moderate and severe. And we have discussed even the criteria for shifting or upgrading the plan of your diet. Okay, now there is a question, as a UG, as an intern or as a PG, anyone will ask, when do we begin antibiotics? So what is the role of antimicrobials? Role of antimicrobials in persistent diarrhea. Okay, so when do we use? Number one, it's useful when there is gross blood in stool. Gross blood in stools, or more than, you had sent the stool for examination, remember? The stool examination will, if showing more than 10 pus cells, more than 10 pus cells per high power field. Okay, and in such a case you should be using quinolones or oral third generation cephalosporin. All right, this was about the gross blood in stool, more than 10 pus cells per HPF. Okay, second one is systemic sepsis. There is systemic sepsis signs. Okay, signs of systemic sepsis, signs or symptoms of systemic sepsis and evidence. Okay, like let's say blood culture has come positive, or the CRP is very high, procalcitonin is very high, child is sick, in shock, septic shock, needing inotropes. Okay, all these things, like whatever systemic sepsis, you have to give obviously parenteral. And parenteral, what do we give? Ampicillin plus aminoglycoside, which can be gentamicin or amikacin. Doses I'm not going to tell because you should be knowing the sepsis doses, ampicillin and amikacin and gentamicin. Okay, and then severe malnutrition. If there is severe malnutrition in the child, that is SAM, a SAM child who's coming with persistent diarrhea. Okay, same thing, ampicillin plus amikacin, that is aminoglycoside you should give. Okay, and in very young infants, very young infants, okay, that is less than 3 months age, very young infants, okay. And the other thing is associated extra gut infections, extra GIT infections. Extra GIT means apart from GIT, okay, like what? UTI, LRTI, okay. And suppose the patient is immunocompromised, like HIV positive patient, okay. It's a child living with HIV. Now that is happened antimicrobials. What about antiprotozoals? We are all fan of giving metronidazole adults. Any diarrhea case in adults, definitely he'll give a metronidazole. So what about antiprotozoals? Who he means any doctor will prescribe an antiprotozoal for diarrhea in adults. Let it be of half an hour duration, 1 hour duration, in 3 days everyone will prescribe, okay. So when do we give antiprotozoals? Based on a stool examination we can definitely take help. That is, we can find trophozoites. If we can find trophozoites in the stool or belonging to Entamoeba histolytica or Giardia lamblia, okay, Giardia lamblia, and in this you definitely will give metronidazole. So evidence based, okay, evidence based you should give. Along with this, what can we give? Now we have discussed diet management. See, this was about diet management guidelines, this was about diet, okay. And then this was about antimicrobials, antiprotozoals also we have discussed, okay. What about some extra help from lactobacilli? Can you give lactobacilli? Yes, you can give. And there is something called Saccharomyces boulardii. These spores and all you can use, okay. These are probiotics, prebiotics concept, you know, so you can use that. Now what are the indications for TPN? Next, management TPN. What are the indications for TPN? Number 1, protracted diarrhea. A protracted diarrhea with recurrent dehydration. Recurrent dehydration, you have to give TPN, okay. Intolerance to plan C, we have already discussed this part. Intolerance to diet plan C, okay. And then last one is weight loss and no weight gain despite plan C, okay. Despite plan C, you have weight loss and no weight gain, okay. This is done. Now there will be some supplements which you will be giving to a child with persistent diarrhea. What are the supplements? Twice daily MVT, minerals, okay, for 2 to 4 weeks. How much time? 2 to 4 weeks. Vitamin A, how much? 2 lakhs for more than 12 months, 1 lakh units for less than 12 months, okay. Then elemental zinc, that is 10 mg per day from 2 months onwards, 2 months to 6 months, and 20 mg per day for more than 6 months age, and this should be for 14 days, you know that. Zinc, elemental zinc. Folic acid, you should give 1 mg per day, 1 mg per day folic acid. Then there is elemental copper, elemental copper is given at 0.3 mg per kg per day. Then there is vitamin D in the last, that is 200 to 400 international units per day, okay. Now suppose the child, along with all this, he is having SAM, he is a SAM case. You will definitely, you know that you have to give magnesium sulfate 0.3 ml per kg solution, right, IM. And then you will be giving oral potassium supplementation, and this is recommended for 2 weeks, okay. Now coming, this was about the supplements, and yeah, and now the last, okay, in the last I'll be talking about prevention. What are the methods to prevent, like how can we prevent persistent diarrhea to happen in children? Are there any known things that which can prevent persistent diarrhea in children? Firstly, we should promote breastfeeding, exclusive breastfeeding, especially in the first 6 months of life. Promote breastfeeding. Okay. Active and prompt management of acute diarrhea. If there's an acute diarrhea, you should immediately address it and manage it. Don't let it become a persistent diarrhea. Okay. And appropriate diet management of a child. Appropriate diet management. Okay. Next will be I'll be talking about some predisposing factors. I forgot to mention, I'm very sorry. What are the predisposing factors? Not etiology as such, but what are the predisposing factors that a child may go from acute diarrhea to persistent diarrhea? If the child is on bottle feeds, if there is malnutrition in the child, extra gut infections, extra intestinal infections like UTI and all we told, right? If there is immunodeficiency of any kind, primary immunodeficiency or secondary immunodeficiency with HIV infection, okay, and there is coexisting infection of in adenoviral infection, EA E. coli, EA E. coli, and salmonella, okay, Clostridium difficile, Clostridium difficile, Candida, and all, as already mentioned, you can write HIV here, okay. So all these things, and apart from this, one last one they say is sometimes there is an empirical use of banned drugs, that can cause, it be a predisposing factor. So this was about the persistent diarrhea. It was a short discussion, but still it is very useful for PG postgraduate to know about persistent diarrhea. We knew about the definition, the pathology, the clinical forms, all right, and the diagnosis. What are the basic, apart from the normal investigations which you'll be doing, like you'll be doing CBP, you'll do CBP, you'll do serum electrolytes, okay, you'll do RFT definitely, okay, because you want to see what are the renal functions, baseline renal functions, and according to the case, like if there's a septic case, you can go ahead for CRP, procalcitonin, blood culture sensitivities, okay. And I told you in SAM cases you will definitely go for SAM management, all right. So we read on that, but don't forget that stool examination, complete stool examination with stool culture, okay. And management guidelines, we spoke about the diet, that is plan A, plan B, plan C diets based on the mild, moderate, severe, and what to do when one doesn't work. Plan A doesn't work, when to go to plan B, plan B doesn't work, when to go to plan C, and if plan C doesn't work, when to go for TPN. We have learned separately each, when to go from A to B, B to C, and we have even learned when to go for TPN, which is after the plan C, okay. So we have learned that, and then we learned a little bit about the antimicrobial management of it, antimicrobial use, and we learned about antiprotozoal use and the pre-probiotic concepts, okay, and the supplements what are to be given, okay, elemental minerals and multivitamins and vitamin A and D, okay, and SAM may you have to give magnesium sulfate and oral potassiums, okay. And prevention, may we have discussed a bit about prevention, a bit about the predisposing factors. So thank you for listening, and please like and subscribe and tell it to your other friends, because this is for postgraduate learning that I've started. Okay, because uh, when I was preparing for my exams recently, I did not find many good sources to make down videos and or notes, in the end you're really stressed when towards the reaching of the exams. You're quite stressed about your source of learning. So that I may help some more postgraduates or junior postgraduates, to me I can say, so that they don't feel lost a bit. It's a struggle to find a good source and a good knowledge, and to make your own notes, and to know it in an examination pattern as well as knowledge pattern. Like, you should be having a good knowledge hold on the knowledge, as at the same time you should be able to answer those questions, whether it be a multiple choice question pattern, or will it be a theory long question stamp type pattern. You should be able to approach that topic. So that is the aim I started these classes from. And to be honest, all these are from my notes which I've made during my postgraduate years. I'm just directly teaching from my notes. Okay, I'm studied them. Okay, so thank you very much. I am Dr. Waheed Hussain, and I would like you to share this with all the postgraduates, especially in pediatrics, who may make use of these videos. Okay, and I don't want to forget to mention my source for this was chiefly IAP textbook of pediatrics. IAP textbook of pediatrics along with the specialty series. Few points are included from the Springer book of pediatric gastro pediatric gastroenterology and hepatology and vaccine immunizing nutrition, gastroenterology, hepatology and nutrition. Okay, so most of it was from IP textbook of pediatrics. If you open that, you will find the sources. Just that for the understanding, and please comment if if you're finding any criticism. Please comment. I made this video after a long time. I had a break. I took a break for some time. So yeah, thank you so much. Thank you for listening. Okay, and please like and subscribe. Okay, thank you.